We are all here. Thank you for your patience. So I just wanted to start off by thanking everyone for being here and being part of this conversation. I am so excited and honored to be helping with moderating this panel with Dr. Holly Lewis. And I've got some special permission to get out of the OR, so thank you, surgery, for that. I wanted to start off by providing a little bit of framework before we get into this conversation. And so what I'd like to do is talk a little bit about the term of intersectionality. And I think that we've probably been hearing this word more and more, but I wanted to give a little history. So it was, for those of you that don't know, it was coined in the 1980s by Kimberly Crenshaw, a Black law professor at both UCLA and Columbia Law Schools. And it was in order to help describe the unique experience of being a Black woman. And the need for this term stemmed from a court case. And Crenshaw will often talk about this DeGraff and Reid versus General Motors. And so Emma DeGraff and Reid and 4 other African-American women argued that they were receiving compound discrimination because of their race and gender, which is what excluded them from their employment opportunities. The courts weighed their allegations of discrimination based on race and gender separately. And they found that since General Motors employed Black male factory workers, allegations of racial discrimination could not be proved. Likewise, General Motors' employment of white female office workers also disproved gender discrimination. And then the court declined to consider the concept of compound discrimination and dismissed the case. And so I think that today, intersectionality is becoming more and more important as we recognize within ourselves, within others, within the people that we live and work with and spend our time with, that there are an increasing number of layers of identities. And some of these identities may be privilege, protection, and some prejudice or harm. And so it's really important for us to consider those layers and how they may affect each of us individually in our everyday lives. So staying with the intersection term, we can see that gender identity and being a person of color are 2 different streets. However, those streets intersect. They may intersect even again as one's gender identity is a man, woman, or someone who has a different gender identity entirely. And so we have found that there are significant health disparities among LGBTQ people of color and LGBTQ people who are white and the general population. And this is related to both COVID-19, loss of jobs during COVID-19, transgender people of color are more likely to have taken an unpaid leave or a pay cut during this time, more likely to have been switched to house or to part-time work, or have had changes to their budget, as well as being more biologically vulnerable. And so that's why I think it's so important for us to really recognize this very special intersectionality. And so under this panel, we have chosen to elevate these strong voices in the community who carry with them both racial and or ethnic identities, as well as gender identities that do not reflect the sex that they were assigned at birth. So the experiences of these individuals are unique relative to those who live on only one or two streets. We have multiple streets that people are living on. We're thinking about intersectionality. And so now I would like to introduce, and I feel like I'm wondering if Holly, if we want to quickly say who we are and then bring it to our panelists who are really the stars of the show here.
Yes, let's begin. Would you like to go first?
Sure. So Holly Christopher Lewis is a PGY2 in the Duke General Surgery Residency. Her clinical and research interests include tissue engineering and reconstructive surgery. She earned her MD and PhD at Emory University with a focus on immunology and chemical biology. She is developing hydrogel models of wound healing and cell therapy within Duke's School of Engineering, and passionate about addressing disparities in medicine. And the use of bioinformatics to better understand social determinants of health. She's active in outcomes research, publishing on medical racism and sickle cell disease, clinical determinants of poor overall survival and after breast cancer, and wound infections, oh, you're gonna have to tell me this word.
Dehiscences.
Thank you, and plastic surgery. With faculty from plastic surgery, she's leading the Duke study on gender health and wellness during COVID-19, with an initiative to understand how the pandemic has impacted transgender and non-binary patients nationwide.
Thank you so much, Dane. I'm really excited to be here. I've worked with Dane at Duke for some of the initiatives that he is a part of with the Sexual and Gender Diversity Advisory Council at Duke. And he and I are both really excited about the folks we have invited today to share their perspectives. And I'm really looking forward to kind of elevating their voices and hearing from these different community elements around the Carolinas to kind of talk more about the role of misinformation, bias, and these structural elements in our society that are really impacting different groups disproportionately. I will introduce Dane. Dane is trained as a clinical psychologist, and he is a medical instructor at Duke in the Department of Psychiatry, Behavioral Sciences. He works as a therapist and performs behavioral health assessments for individuals who are identify as transgender and may be interested in exploring their options for gender affirming medications or therapies. Dane also is the director of LGBTQ+ initiatives at the Duke Office of Diversity and Inclusion, which is a part of the School of Medicine. And he is the faculty advisor for Duke Med Pride. Dane really enjoys teaching medical learners, physician assistant students, physical therapy students about the importance of cultural disparities, cultural determinants of health disparity outcomes. Since coming to Duke, Dane has conducted over 70 different trainings and workshops focusing on best practices for working with LGBTQ patients, clinical learners, as well inside and outside of the Duke environment. He is a co-director for equity in research at the Clinical and Translational Science, the Duke CTSI Institute, where he plays a role in curriculum development and also is a consultant focusing on promoting diversity, equity, and anti-racism in Duke's research environments. Dane and I were very excited to be here. Thank you.
And so now I'd like to introduce our panelists, and we have a fantastic lineup of people. I was so excited and honored when everyone said yes. This is like the dream team, and so I'm wondering if, this is something that I can either introduce you, or if you would like, you can introduce yourself and talk a little bit about what each of you would like to highlight. Sam, you're kind of next on my screen. Would you like me to introduce you, or would you like to say something about yourself?
I don't mind introducing myself. Can everyone hear me?
Yes.
Awesome. Hi, so my name is Sam Aldave, and my pronouns are he, him, and they, them. I am a third-year graduate student at Duke. I am in the Divinity School. Currently, right now, spending a lot of time working on my thesis, which is around the intersection of Blackness, transness, and being a person of faith.
That's amazing. Thank you so much for being here.
Of course.
And then, thank you. Vanity, you're next on my screen. Would you like me to introduce you, or would you like to introduce yourself?
Sure. Thank you, Dane. Good morning. It's still morning. Good morning to everyone who's here in attendance and in viewership. My name is Vanity Reid Deterville. I respond to she and her pronouns. I am a recent graduate of the College of Charleston in Charleston, South Carolina, with a degree in political science concentrating in public policy, hailing now as the new Gender Resources Advocacy Support Program, also known as GRASP, Program Director at the LGBTQ Center of Durham. And I am very excited to share my thoughts with you all today on mistrust and misinformation.
Thank you so much, Vanity. We're so happy you're here. Roxana, you are next on my screen.
Hi, everybody. Good morning. I'm so glad being here with everybody here this morning. So my name is Roxana Picazo, and I've been working for El Centro Hispano for these last 2.5 years, working as a coordinator support transgender woman around the Triangle area. So I'm very glad to share any thoughts or any help I can provide to the community. Thank you.
Thank you, Roxana. And Candace, would you like me to introduce you?
Sure.
Let's change it up a little, okay. So we have Candace Cox, who I have had the privilege of hearing speak many times. And she is part of EqualityNC C4 board since 2016, and she serves as the secretary as well as sitting on the executive committee. Candace also sits on the board of the LGBT Democrats of Wake County and previously on the board of the Crepe Myrtle Festival. Candace holds a BA in sociology from NC State and has worked with helping to develop our inclusion policies for numerous triangle and national organizations, including the Human Rights Campaign. And so she's also the sole transgender person to have met with Governor Pat McCrory regarding HB2 as this bill was being passed. She's been featured on CNN and MSNBC, and lending a transgender voice and perspective to issues that come up. And she is a passionate educator to others about the need for inclusion, improving the lives of transgender individuals. Her personal time is spent enjoying the two things she loves, her family and travel. And so we're so glad to have you here, Candace. Thank you for joining us.
Thank you so much. And shopping.
And well, of course, shopping, yes. And Rebby, last but not least, would you like me to introduce you, or would you like to introduce yourself?
Awesome. I can take it from here. Hey, everybody. Good morning. My name is Rebby Kern. I use the pronouns they, them, and theirs, and I'm the Director of Education Policy at Equality North Carolina. It's really great to be here with all of you. I've been working with the organization for just over a year now, continuing on over a decade of experience supporting queer youth within policy, within leadership, in schools across the nation. This is a crucial time, and so it's important to be able to be present on this panel as we navigate some of the weirdest times, the hardest times that we've had. And so any opportunity to help create some education around experience, it's always an honor to be among other BIPOC trans folks. So thank you all for taking your time out, for being here as well.
Thank you, Rebby, and thank you all for being here. So this panel is going to be a conversation style. And so we have questions that we're going to be asking the panelists and inviting people to answer or add, or if a discussion evolves from this, then we will spend some time doing that. So we'd really like to be organic and kind of hearing about the the perspectives from the panelists. And so I will start by asking the first question. So at Duke, we strive to provide every patient with the best healthcare experience possible. However, we also know that often larger healthcare systems like Duke are especially at risk for creating mistrust through our patient interactions for a variety of reasons. And for example, those could include having inaccurate information in our electronic health records, a higher turnover rates among staff, and the nature of academic medical centers as having rotating trainees, et cetera. Also the hierarchical structure within medicine, I think, is highlighted. So given all of that, in your experiences with healthcare systems, have there been instances that have made you mistrustful of those systems or medical care in general? And I don't know if someone.
Yeah. I'm sorry. I will happily start that off.
Thank you.
So I think that's kind of an obvious, yes, for me being a person who's brown, because that, I always say, is what walks into the room first before my gender identity, anything. I'm a Black person. And so has there ever been an uncomfortable? And for me, the answer is, has there ever been a comfortable would be the better answer. I'd have a shorter way to respond to that, because I have all of the stigma, on me. Like, I can go somewhere and, it's never, it's the microaggressions. It's never, your insurance card. It is, do you have insurance? And just that little thing right there, like, it's like the assumption is that I might not actually have healthcare coverage, because people who belong to my demographic, we don't. And it's those little things that really stick in you. And then you carry a burden with you when you hear people talking about studying sickle cell, or talking about diabetes and high blood pressure. And I'm aware that Black people disproportionately suffer from all of those things. So I, all of a sudden am this person walking in who's like, oh, my health is in jeopardy. My lifestyle could lead me to being exposed to all kinds of, you know, things. And then as a trans person, I'm like, do I ever feel uncomfortable constantly? Because I have to explain to you my process, what I've had done, if I've had surgery or any type of physical augmentations to my body. And then for so many trans women, especially trans women of color, was it surgically done? Was it done by black market, you know? Is it free-base silicone? And then we know that physicians, they're not taught anything about that in medical school or residency. So now I have to educate you, which makes me feel even more like an outsider and like a freak, because I'm having to explain myself to you because it's so foreign. So yeah, I'm like, every encounter with healthcare is uncomfortable when you are, you know, brown. And then when you add in the intersectionality of being trans and a trans woman, like, I love the questionnaire. It's like, when was the date of your last menstrual cycle? I didn't have one. Oh, when did you have a hysterectomy? I didn't have one. Like, I know enough about medicine to know that those things aren't even pertinent right now. I just need, you know, a painkiller because I have a toothache and the dentist isn't open on the weekends, kind of thing. So yeah.
Thank you so much for bringing all of that to the table. That I think, no, please don't apologize. This is why we are having this conversation. I think we want to understand how mistrust and the things that we do as an institution or even as individual community members or providers really affect who we are. And it, from what you're saying, it sounds like I can't even imagine taking all of those things into account in a place that's supposed to take care of you and really feeling like and really truly having the burden of almost guiding people to take care of yourself.
When you're Black, you become accustomed. You grow up knowing that the system just isn't here for you. I don't view, my parents are physicians, and even I will say, I don't view, you know, doctors and hospitals and everything as being an institution of aid and help, but more of a laboratory, you know?
Yeah.
Like for me as a Black person, I'm like, it's a laboratory. That's all it is.
Sam, it sounded like something there resonated with you.
Yeah, a lot of what Candace said resonated with me. I just want to affirm all of her statements and that feeling of like your Blackness like preceding you. I feel like I've experienced that to a really great degree. So I live with bipolar disorder, and I live with bipolar type 1, which means that I can have some rather extreme high manic episodes and pretty extreme low depressive episodes. And I was hospitalized one time. I was hospitalized a few times, but this specific time it was involuntary for mania. And I, you know, had been taking my medications, but like, and so I took my medications every day. So I knew which medications I was supposed to take. And then when I got to the hospital, they started trying to give me medications that I had never heard of before. And so I wanted more information about what these medications were that they were having me take, because they weren't on my chart. Like, no doctor that I'd ever seen before had prescribed them to me. And so I wanted to learn more about them. And I was getting, when you're in a manic state, you're already on the edge of agitated, like all the time. And so I was becoming more agitated at the fact that no one would answer my questions. They were just saying like, just take these pills, because you need to take them. And what ultimately ended up happening was they sedated me. They injected me with something that sedated me. And then I woke up and I was handcuffed to the hospital bed. And I was like, what happened? Like, I don't understand. And a Black nurse came in the room and she was like, honey, you know, when you look like us, you can't make them feel threatened, like in any way. And your questions felt like a threat to too many white people. And like, I wish I could take you out of these handcuffs, but like, you have to be in them for at least like a certain number of hours. And it just was an extremely like dehumanizing experience, on top of just feeling like so disempowering, like just because of the fact that I was Black, like I lost the ability to be an advocate for myself. And that was just very challenging.
And it almost sounds like the nurse who came and talked to you after the sedation kind of wore off was even in a position where she wasn't empowered to help you, but she understood like the experience, or at least to a certain degree, kind of what you had gone through, and that racism was part of it. And yeah, wow.
May I add a small note about that?
Please.
Both Candace and Sam, thank you for sharing and being transparent with us about where we slip into the gaps when it comes to our linkage to healthcare. I won't speak on it too much because I see that I could connect it better with the second question. However, there's a reason for the weakening of the rapport between the medical and the Black community and the medical and the queer communities. The struggle of that relationship is largely historical, and it is also rooted in racist experimentation. And so I'd like to come back to that thought for the second question, so we can kind of understand why there's a historical mistrust that we're speaking about right now.
All right,
Yeah.
thank you.
Oh, sorry.
Go ahead.
We'll go to the second. No, because Vanity's got me. I'm like, yes, yes. Thank you for going there. I'm like, oh, do we have to wait for the second question? Because I'm like,
Okay,
oh yeah,
sorry.
No, let's just go in. Let's just go in. I think it's important.
So what you brought, you know, kind of to the forefront, Vanity, is the fact that and also Sam, is that for African Americans especially, but also, you know, anyone who is of brown skin, honestly, health issues is such a stigma. You know, it's something that we don't talk about within ourselves, and our families, and mental health issues. And so what we find is that we disproportionately are going through life misdiagnosed and undiagnosed. You know, if you go to a group home, if you go to a children's hospital for psychiatric help, you will see it is disproportionately represented by Black and brown people. And that does not mean that we suffer from, but that means honestly that we are misdiagnosed, or we just go, you know, by the wayside. And for me, the problem that we're finding is that, you know, we see people going into the ED, and the physicians are missing the opportunity to say, perhaps this person has FASD. And instead, we just assume that this person's just, you know, that's how they are, you know, and we know that is the truth. And the healthcare system really needs to recognize that, you know, we aren't white America. You know, we don't grow up talking about stuff. We don't grow, we don't, in our community, we don't have words where we, you know, bipolar. I mean, I can tell you in my own personal experience that that word is something that is a rarity within the African American community, you know, like we don't really talk that much about that. And a lot of that stems from that experimentation. We want to distance ourselves from disease. My grandmother is still alive. She was born in Alabama. She knew people who were affected by all of that awful, you know, experimentation. And that makes her see a white coat as something that's going to harm her. And so she distanced herself from, yeah. Ooh, I'm sorry, Van. I'm gonna shut up.
No,
Wow.
Speak,
no.
Vanity.
It's
Because everything you were saying, Vanity, I was just like, yes.
So since we're gonna open the can of worms, Dane, if I may, I
Please.
guess I'll go ahead and hop into my answer. I read a book about America's legacy of enduring injury and healing by a Black female scholar, Dr. Joy DeGruy, called Post-Traumatic Slave Syndrome. And within this book, she talks about the history and the inception of modern medicine as we know it. She speaks about gynecology as the practice we know today, and its founding by Dr. James Marion Sims, who experimented fiercely and avidly on enslaved women and their daughters. And so when we see that gynecology, a practice of medicine, which is highly revered, respected, used today, and its inception rooted in racist experimentation and white supremacy, we can begin to understand the historical tension and mistrust between the Black and the medical community. I think it's especially important to recognize that biomedical warfare and medical racism has been tethered to American medical society in modern times with things like the Tuskegee experiments, with things like how we handle the HIV and AIDS epidemic, with things like how we handle cancer, with things like how we patent diseases, and the ways in which we can medicate folks because of our patents on those diseases, and the right for different countries to use certain medicines to treat folks with those diseases. It is all very rooted in capitalism, white supremacy, racism, and slavery. And so we can begin to understand with that framework why there's a mistrust still to this day between those communities. And then we can tap into the other communities also. But when you talk about intersectionality, and you talk about the basis of Kimberly Crenshaw coining that concept, you have to go deeper into what the concept is and what information it borrows from. And so Black feminist thought provided the concept knowledge for intersectionality. Patricia Hill Collins talks about the Matrix of Domination. She talks about race, class, sex/gender being the means in which we are dominated. Bell Hooks talks about this matrix as the politic of domination, right? And so race, class, gender, or sex have been the means in which we have categorized and decided or labeled as inferior or superior historically. And so that matrix of domination was used and created and fostered to benefit those who created and founded modern medicine as we know it. And we are still living within the confines of that matrix today.
Thank you, Vanity. And Rebby, I have seen your head nod so many times. I just want to point that, do you have something to add to this?
I do not.
Okay. It's just, are those nods of agreement then?
full support, and that's just kind of the whole point, is like continue listening in, and I will share when it's time for me to share, and I just uplift everything that's been shared so far.
Okay.
Can I just point out one quick thing that's just because we're speaking truth, and it's for me the umbrella. You know, when we're talking about like disparities and you know, how do people feel with their intersectionalities and everything. And Vanity, you really brought up something that I think more people need to know about in terms of, you know, how modern medicine really kind of has come to where it is. And we're all sitting here speaking, you know, because of Duke. And Duke has this very wonderful prominent name. And Duke has a wealth of financial resources and everything. And Duke was built by slaves. I'm like, you know, a few hundred years ago, my ancestors made Duke what it is today. And yet I am only graciously able to benefit slightly from that. And I, you know, it's like, do I feel like modern, you know, what kind of problems and everything do I face? And I'm like, I'm supposed to go into a hospital that my ancestors, you know, funded on their backs.
Right. Yeah. At what cost? At what cost is it truly a benefit? When you think about the grand scheme, when you think about the historical context of who you are and the many past lives of who you were, and at what cost is it truly beneficial to who you are and who you will continue to be generations later?
Mm-hmm.
I'm sorry, I had to point that out.
I think that's a very important point. Roxana, I wanted to invite you in on
Yes.
this.
So I wanted to basically add, I have a lot of stuff to add in top of my friends here says. I'm gonna say the Latinx community transgender are feeling the same way. They are not treating the right way when they're trying to go and get like health benefits. Why? One of the first mistakes clinics and hospitals are making with the Latinx community is that a transgender woman doesn't identify with their legal name as it's writing on their birth certificate. They always choose a different name because that's how they feel. That's how they want to go with that name. So that they always, and I'm telling you this because I help my new participants of my group. I take every time to get hormone therapy. They always, by the nurses, they always get called by the legal name, and that has to change. That's very rude of nurses being calling patients by the legal names. And that's one of the things it has to change. Really, it has to change. Because I don't see the reason why a lot of clinics around the Triangle area are taking these notes just to make them comfortable calling by the name they want to go by. But they're still missing it. They're not doing anything to make that happen, to make them to be more comfortable in the health areas. And I remember I was there last year before the pandemic starts, and I was taking this girl with me, and her name is Vanessa, and her legal name was, I think, Jose. Well, the nurse came out and he's like, Jose. And I was like, I feel so bad that I came to the front desk and talked to the lady, and I told her that has to change. You guys have to improve the treatment to the patients because this is not fair. And I do feel the same way as Vanity and Cox was saying, because I think a lot of things has to change, but they're not happening. And we wanted to have better services for the transgender community, no matter if they're Black, they're Latin, Hispanic, we need to have better services. because I remember 2 years ago, I took a trip to San Francisco, California. The services up there are so great. They're so great. The girls, they also getting like free surgeries, like breast implants, sex vaccination, everything. They got like free surgeries up there. And I don't understand why we cannot have stuff like this here in North Carolina for our community.
I think I want to really validate the perspectives of each person who has like spoken. It's very, very important to recognize the perspective that you feel when you walk into a clinic, whether it matters, the greeting you receive, the name that you're called at the door, the structural racism that is literally built into the buildings, the hospitals, the clinics, the fact that our institutions, our entire nation was built on the backs of slaves. It's important that we recognize that when we ask patients to come into our clinical environment, that we're asking them to trust us. And in many ways, we're offering them in exchange really just demonstrated centuries of medical abuse upon the Black and brown bodies. It's a very challenging dynamic, and there's nothing that I can say that can negate or change those perspectives. It's really important to uplift them, and I thank each of you for sharing those thoughts. As a clinician, I work in healthcare, and I also see those things as a patient too. I've worked clinically in Atlanta, here in the Triangle. I did clinical rotations in Los Angeles and in San Francisco. And then I've also been a patient in New York City. And I'll say that sometimes these encounters are better in other cities, and sometimes they are not. Just as patients are misgendered by name and by pronoun here occasionally at Duke, I still saw that in Los Angeles, and I still saw that at places in San Francisco. And it's always stinging, and it's always burning. And I think that, you know, the racist presuppositions that clinical staff have, you know, hearing Candace, your words about when a clinical person asks you if you have insurance rather than for your card. These are the types of interactions, the types of microaggressions that people encounter every single day in our clinical environment. And we can't make any headway on addressing misinformation and mistrust unless we're able to actually meet people at the door with acknowledgements of our complicity in the structural racism that oppresses so many. These are linked problems, and I think that it's not unique to the Triangle. I think we see these across the United States as well.
Thank you, Holly. Yeah, so I'm thinking about where to go from here. I'm just so grateful for your willingness to speak truth to your experiences. And I'm wondering, thinking about the microaggressions, you know, we've talked about how many different types of microaggressions and how, and you know, just from this conversation, I'm thinking, my goodness, like, how could there not be mistrust towards the medical system? And really thinking about all of the really macro level changes that need to happen to address, or at least, you know, it's almost hard to be hopeful that there will be such a significant change. And I think we can do our best to try and mitigate some of these things that you all are, especially the things that we can change, at least.
Can we ask Sam, Candace, Vanity, Rebby, Roxana, can you, what changes do you think that you would like to see, or that can make impact in these situations? What can
the
be done?
for the Hispanic community, I would like to see something like do the right pronouns for hers. At least to call, when they call their names, to call them by the name they want to go by. And maybe have the nurses training people, get the training for the nurses. Because I'm also went into situation, and this is separately for the health issues. Transgender Hispanic are getting mistreated in work areas. And we as an organization, as El Centro Hispano, have the LGBT support groups. We have been coming to different places to train employees how to treat LGBTQ people that are working there. So I know it's hard. It's hard for everybody to do it. But for me, at least in hospitals and clinics, they need to start calling patients by their names and by the names they want to go by. And I think that's, for me, that's basically one of my main points for the clinics.
I feel like that is the least we could do.
Yeah, and I think like
respect.
Respect is huge.
Oh, sorry, Sam. Sorry.
Go ahead, Candace. No, you can go ahead. I'll go after you. You're good.
So, for me, something that I think, especially for trans Black women and trans Latinx women, especially too, is respect. You know, it's really easy to transition when you have access and you have money. And it's easy to respect that. But imagine having to do whatever you possibly could to be who you were, and to have to engage in survival sex work. It's not called prostitution, it's called survival. It means that you are the kind of person who is willing to do whatever it takes in this world for you to be who you are and to take care of yourself. I mean, that is the fundamental of being American that we respect so much within people. And yet so often within my community, I see it as being something that is frowned upon, that is looked down upon. You know, we look at them and we say like, oh, drugs, you know, like they're using drugs and everything. And I'm like, yeah, they're self-medicating because they can't afford your medicine. You know, so respecting that and recognizing that, like, stop putting labels on things and stop making people feel like there's something wrong with them because they're simply trying to survive in a world that they didn't create. They didn't make this world. They didn't make these rules, you know. Trust me, if we know what happened, if I could like actually write legislation in North Carolina, it'd be a completely different state, you know, but I'm here. We're here just trying to survive. And when we go into clinics, every single aspect of who we are is a negative and a mark against us. And it is something for someone to look down their nose upon at us. And I'm like, that's got to stop. When we come in, I'm like, be proud, because it takes more courage than I think people ever will realize to hold your head up high and step outside of your house and be Black and a trans woman or Latinx trans woman, you know, and survive in this world right now that we live in. Like, whatever brought them into your clinic, however they got there, applaud it, support it. Because they're going through, I mean, the journey from their home to your clinic is one that you cannot fathom what they have gone through just to be there and to be who they are. Like, yeah. Sorry.
Candace, I just want to give you so many snaps, Candace, because that's so real. And I think like the question, I would want to see training on the part of like hospitals and clinics, but like a better form of training. Like I feel like I have a partner right now who is in her first year of medical residency, and they in North Carolina, and so they went to 2 days of Racial Equity Institute training, which is great as a starting point, but I feel like it's their ending point as well. And it's not enough to just have like a block of time, 1 or 2 days to say, we're going to talk about racism and how that shows up in our workplace and how we can stop it. And we're going to talk about transphobia and homophobia and how that shows up, intersectionality. Even if you talk about all of that at some point with everyone who's working in the clinics and the hospitals, that's not enough for them to learn it and internalize it. Because like in learning and internalizing the concepts of like Racial Equity Institute and like anti-transphobia, anti-homophobia training, you're also unlearning decades of what society has told you subconsciously and out loud about who deserves to exist and live and get medical access in this world. And that unlearning process is very difficult for adults. I spent 4 years managing adult teachers, and it is very difficult once you get past a certain point to unlearn the things that you've been told in the past and learn new ways of being and operating and moving throughout the world. And I feel like it needs to be a regular, ongoing form of training so that like nurses and hospital staff know, like, okay, we're going to look for pronouns on this chart. We're going to look for the preferred name on this chart. And that's what we're going to utilize with this person. And we are going to use like a standard, even with the microaggressions, a standard way of asking for insurance across the board. And be very intentional about it, not differing based on the color of who you're facing. I just feel like a lot more training and learning needs to be done, especially someplace like Duke that has so much money. Like, why isn't more of it being spent on training around these best practices?
And it's an educational institute.
It is, but when you're talking about that education, I'm fortunate that I'm credentialed and accredited and published, but the people that we're talking about that need so much are the people that are never given the opportunity to do an in-service at a clinic. Bring those people in. Value, the fact that, okay, they're not going to come in with a degree and a PowerPoint and an organization that has backed them, but they're honestly the ones that you need to be listening to. They're the ones that can school you. They can teach you so much more than someone who, such as myself, who, as strange as it is to say, I have a bit of privilege compared to my brothers and sisters, and so I can tell you about their stories, but I can't completely relate. You need to invest in actually educating yourselves on the people that you want to serve. And the only way to do that is, you got to get it from the fish's mouth.
And that part is so important, and to acknowledge that even in the space, like as a BIPOC panel, having white moderators says something very specific about what's showing up in the system at large. And to think about, if the question is what needs to change, it's the same conversation we're having outside of the medical industry. It's across the whole nation. Everything has to change. And if the system continues to reinforce cis heteronormativity, then it will never serve any of these panelists here the way that it ought to, and the way that it continues to prioritize white cis bodies, and particularly men. And we have to unpack that in a way where we give up pity. Like, I'm not asking for pity, I'm asking for the system to change and to be different. And so we have to give up, like, if anybody out there is watching this and like feeling like the sad and the guilt and the pity, okay, cool, process that and then do something. Like, go talk, because I'm not asking anybody to feel bad. And that's happening across the board with this concept of allyship. And like, we're asking for co-conspirators to actually challenge the system and do something completely different. And so until we can have a BIPOC panel that is led by a Black trans person from within the system, there will be forever mistrust.
Yeah, I think Rebby just really outlined the difference between allyship theater and co-conspiratorship. Very two distinct things, two whole different types of functions when it comes to liberative work and then standing in solidarity. But one thing that I feel like definitely needs to change, and this relates to research hospitals specifically. Coming from Charleston, South Carolina, I dealt with the Medical University of South Carolina, which was the premier research institution in the state of South Carolina. One of the practices that research institutions tend to have in place is the supervising or the visiting in or shadowing, if you will, of residents to care providers on their client visits, which can be very detrimental. It can be dehumanizing, and it can strip the dignity of the client who's there to all of a sudden have a resident student who has no expertise in HIV or AIDS management or transgender existence to suddenly be shadowing your doctor in on your medical visit, where you talk about all of the intricacies there are to discuss about yourself and your body. Medical universities, research universities have a tendency to allow that to happen. And the cultural competency that needs to go along, the training that we're talking about that needs to go along, deciding when it's appropriate to bring a resident student in to shadow an office visit, I think is something that definitely needs to be revised in order for this demographic to be benefited.
Such a good point. I'm Dawn is bringing in a question that from, I don't know if you all can see this in the chat panel from thank you all so much for your knowledge, expertise, and compassion. I'm honored to be listening to this call. I'm a white nursing student at Duke. We are taught to go into the patient room and ask a set of questions to establish how someone is doing. For example, we asked a lot of questions about pain, location scale from 0 to 10, duration, and also if someone has a pain goal. Would it be appropriate, helpful, beneficial to ask something along the lines of, have you experienced discrimination since coming here? And if so, how can I help with that?
It's too late to wait until they're in the waiting room to ask that.
Yeah, I mean, I think that's a really tough one, you know, because it's, on the one hand, yes, I think it's good to show that care, but on the other hand, are you likely to get a authentic answer? No, because what is going through my mind is motive. Why are you asking? You know, why are you asking? And like now, you know, because like Rebby was saying, like, so I've gone through all of it, and now you're asking, like, why didn't the receptionist ask me?
Yeah.
Like,
Yes,
you know, like,
exactly. Yes.
you know, so now I'm questioning, like, well, why are you asking? Like, all of a sudden, you know. But on the other hand, yes, I think it's important because that trauma that someone experiences from discrimination, when we're talking about on a scale of 0 to 10, tell me about your pain. You know, my foot is hurting. The discrimination I've experienced has exacerbated that. You know, it's like, and we know from a medical standpoint that literally is possible because, you know, all the release of all of those hormones and everything everything that kind of takes place within a person when they're feeling attacked or whatever, or defensive, can make it worse. So yes, but I think that we need to address that earlier on in the interaction with the patient.
I think it has to be done in the reception area, something like that.
Yeah.
And that,
Well,
that
I think
question
like
needs
even
to get
if
asked up. Go for it.
Oh no, I was just gonna say like even if it was a helpful response or question to ask, the amount of help would be limited to like on an individual level when so many of these issues and challenges are structural and systemic. So I think you have to just be very aware of like what the actual long-term goal is, like equitable treatment across the board, and what are actions that can be taken towards that big picture goal.
And
Yeah.
something
And asking us, it's just, it's going to be difficult for us to answer. You know, Latinx and Black people especially,
Yes.
we live every single day with so much discrimination that if you ask me, have you been discriminated against today? I'd be like, no. Well, I mean, probably, but like, I can't sit here and like rattle off, like if I, you know, it's like, just give me my medicine. You know, it's like, we have just learned to navigate life and society with discrimination. Like, we're so accustomed to it that we don't really see much of a point of saying something to someone, because we're like, what's going to happen? Nothing.
And this goes back to what Candace was saying earlier too, that if my medical professional is asking me these basic questions that don't reflect a diverse gender expression and experience, then how can I even think that this particular institution is also going to have an equity lens around race, to where the person who's asking that question should have had training, should have been able to have an institutional picture to know and to create different questions and different data sets that I can come into a room and I know that that professional is already going to have a lens into that and create some space, but it doesn't. It's still catering to people who do not experience discrimination and have proximity to power as they navigate that system. And so that's the true question, is that question has to go back up and say, why do we continue to choose operating the system in this way?
Mm-hmm.
Yeah, and Rebby, I think it was in your training that one of the definitions of privilege that has stuck with me is the proximity to power and resources, and that has definitely changed the way I've been thinking about a lot of things in our work and the health system. So I thank you for that. And I know that I think Holly had a question that she was going to ask.
Oh, I wanted to ask all the folks how the COVID era and the quarantine and the ongoing pandemic has exacerbated these issues for each of these concerns.
I don't even know where to begin with that. I mean, COVID has really just trans, femme identified queer people of color, all of them they're going to be the demographic that we need to really be paying close attention to their survival. in the time frame, because we have taken away so much of their ability to survive, you know, and we have forced them to be exposed to COVID, but also increased their exposure to other things that can affect their health and their life. You know, if you're a drag queen and that's how you make your money, and that's wonderful, but we've taken that away from you, and you can't get unemployment, you can't get those services. And if you engage in survival sex work, it's called survival sex work, and COVID is not going to really change that. So, you know, it's really kind of addressing the fact that we have an institution in this country that, you know, makes it so that we can talk all day long about exposure and, you know, quarantining and all of that, but that for some people, that it's a moot point. You know, it's like they're not talking about all that stuff. They're just trying to survive. You know, let's keep it real. If you live in a motel on Capitol Boulevard in Raleigh, they charge by the week. You got to make that money. You got to come up with it. And COVID or not COVID, you're going to do it. And there's no resources. You know, what resources are there? You go to a church, like, and explain yourself and get help with what? Yeah, I don't even know how to answer that. I'm sorry. I'll shut up. I'll totally let someone else, because
I want to say something about it. I'm gonna say probably with this, during this pandemic, I remember when we go to quarantine, I was basically connecting with my participants over Zoom or either individual phone calls. And I'll be honest, what I was listening from them, it was frustration. They were feeling bad to be sitting at home, either because they lost their jobs. And I think they were needing to have some mental health. And we were not having anything of that available at that time. And people that were planning on doing mental health for participants or people around transgender community, they were charging a lot of money. Like, they think there was like the advantage to take and just make money off of it. And I think that was not fair to do. So we need to start having also like a mental health support group in the area where we can just basically call and they will be there to give the support to the community, because the community, they do need the support, especially in times like this. This is something that we need, not something that is going to be, doctors are going to be making money off of it.
speak on it. And I'm going to call Dane out on that, because I'm going to be like, speak on it. And Dane, I'm like, that's you. It's
Yeah.
like free clinic.
Yeah. Well, and this is something that I'm wanting to ask, because, you know, even though we're all on a Zoom platform right now, if we weren't, the invitation would be to come to Duke, right, and talk about this. And I'm wondering, like, hearing from what Roxana is saying, and and quite frankly, after hearing just these horrific descriptions of the experiences I've had coming here, like, is a way of could a way of building back trust being going out of Duke to speak to people? Yeah. And is that, you know, because I feel like asking people to come to Duke creates a lot of other burdens and costs, parking, and then you know, everything that comes in walking through the door, and then the whole time you're there.
Yeah, create neutral ground. Go to El Centro Hispano, you know, and go to the LGBTQ Center of Durham. Go to where they're at. Like, I think that neutral ground, you know, goes a long way.
Yeah,
Yep.
because just to like second what has been said, even just like thinking about the experience of coming to Duke, like I'm a student at Duke, and I spoke on a panel at Duke last year, and I just couldn't stop thinking about the audience who I was speaking to and how much privilege was within the audience that I was speaking to, and like how it felt like me being a Black trans person of low means financially in the world was just like on a platform to educate these like more privileged, predominantly cis, predominantly white people. And it just felt like another form of Black and trans people not getting paid for their worth. Black and brown trans people not getting paid for their worth.
Thank you for saying that, Sam. And I'm, yeah, so there's a question, how do y'all feel about questions being asked about, one, what were your gender at birth, and two, what gender do you identify with now?
I have some thoughts on that, just because again, from being hospitalized in the past, like I've had experiences of talking to nurses who called me like young lady, and I would tell them like I'm not a young lady, and they would be like, oh, you're just like confused, or you're just sick right now, but like you'll come around. And it's like experiences like that really have me thinking about, well, experiences like that and experiences like with weight, because according to like the BMI, I am overweight, and that comes up in a lot of conversations with like my primary care physician. And I'm always like, what is the purpose of this? Like, towards what ends are you asking these questions about gender? Towards what ends are you asking these questions about weight? Like, what are you trying to accomplish? Because a lot of times I feel like, at least in my experience, I've been asked questions about gender for no reason. And so I, didn't have a gender at birth. And B, now you're asking me to just re-invoke for you what some cis white dude doctor assigned me when I came out of the womb, which I had no say or voice in at all. So to that first question of what gender you were at birth, I would really wonder about like the purpose of that question, and even like your current gender. Like, I think that gender can be something that people live out loud, and it can also be something that's like personal to people. So if there's not a very specific and important goal you're trying to reach through those questions, I'd wonder about asking them.
Yeah.
Yeah, I'm agree with that
I
too.
think yeah, go ahead.
Yeah, I'm agree with that too, because to be honest, for me, reading that question, what was your gender when you were at birth? For me, I'll be honest, it sounds offensive. I mean, I don't know. I don't know what you think, Candix.
I mean, like, just like, what was your gender at birth? And I'm like,
Yes.
are you clocking my tea or something? Like, are you trying to say like I look like a woman, but you think I might not have been born a woman? So are you asking, am I transgender or am I Serena Williams? Like, it's, you know, but so for me, I think it's okay to ask that with the caveat that first you explain why you're going to ask certain questions. And the
Yes.
reason you explain is you educate. So you educate because that's what you're here to do, is you want me to, you're a doctor, you're not a funeral home director. You're a nurse, you're not someone who's working in, a crematorium. So you're here to help me live. And if you're asking because you need to find out whether or not I still have a prostate, because I'm over the age of 40, if I still have a prostate, I need to be receiving a prostate exam because of prostate cancer. Now I am okay telling you, because you're not asking for anything other than, I respect you as the woman that you are. I see you as the woman that you are. I want to help you live as long a healthy life as the person who you are. That just means I need to address certain things. If it's the opposite, do you have, are we getting to where it's like, do you still have your, mammary glands and breast tissue? And do we need to do examinations for breast cancer? So establishing the context of the question first and expressing the care that's behind it. Because otherwise I think it kind of really speaks to what you were just saying, where it's like, why are you asking? You need to establish that care and that sensitivity first, so that I'm not questioning your motive. And I think that's really true with any questions when we're dealing with sensitive topics, is you need to establish that level of care and sensitivity so that I don't question your motive.
And just to bring that up, I have to tell you, LGBT community is so sensitive with questions like this.
Mm-hmm.
So we have to be so very careful on which way we're gonna do it, because especially me working as a coordinator for the Centrist panel, I've been seeing it a lot. The community always asks me like, what are they asking me these questions? Why do they want to know this? Why do they want to know that? So we have to be very careful how we're going to be asking stuff, especially going through the people, because we don't know, you guys don't know how that person might react back to you guys.
Yeah, just to reiterate also, want to be on the note of being particular and careful with the language we're using. We should be asking the questions of, if it comes to that, the sex assigned at birth, because the gender and the gender expression is something that's going to be socialized. And so at birth, you have not yet been socialized. So we want to make sure that we're speaking about sex assigned at birth, not gender.
And I'm one thing that I think is, yes, Vanity. I think that's absolutely right, and it. I'm hearing too about like one, and correct me if I'm wrong or not getting this, but one way to at least reduce mistrust would be to explain why you're asking a question about someone's about gender or about anything during an appointment, because of, and that's a result of the trauma that has already been experienced, because there's already like a threat response, and I can't remember exactly who it was, but when someone sees a white coat, it's like, kind of that's a threat cue, which that's, wow, yeah, and I can totally see why. But if in thinking about like explaining why someone is asking and having that, and making sure that it's a good reason, like they're coming in for an earache, there are questions that don't need to be asked about all these things.
Yeah, we call that the transgender elbow syndrome, which is when someone comes to the emergency department with a broken arm, and they broke their arm, and maybe they fell off the bike or something, but suddenly all the questions that are asked relate to that person's genitalia and what they were born with, what they were not born with. Could this be a factor? Maybe the hormones made it more likely for their bones to break, et cetera, et cetera. When in reality, they just fell off their bike and broke their arm. And their gender expression or identity doesn't necessarily have anything to do with their arm. So let's just focus on the patient's arm, which is something that's often lost.
And I think right now with everything that we're seeing happening to people of color, not just queer, but people of color, it is something that I think healthcare providers have to accept, that in terms of posing a threat, it's like police, healthcare, government, all are equally something that poses a threat right now to people of color. And for people of color, that's very palpable, and it's so that guard is going to be there and asking me to be vulnerable and asking me to disclose more and more, really kind of, it's like, what's going to be the next question? Where are we going to stop? Wait, how far are you going to go? Are you going to ask my citizenship status? Are you going to ask about my genitalia? Are you going to ask about STDs that are not, it's like, how far are you going to go? And then when am I going to get hurt? Because we are hurt. And, for people of color right now in this country, I think that everything has shown us that it isn't in the dark alleyways with the skinheads who are hurting us. It's the people in uniforms. It's the people who are supposed to, be the ones that we go to for help. And they're the ones who are hurting us right now.
Betrayal. And you said something about vulnerability, and I've been put on my psychologist hat for a minute, and kind of the recipe for trust that I had always thought about is that it's safety plus vulnerability is what equals trust. And if as a medical system we are not keeping you safe when you are at your most vulnerable, then that is why would we expect for there to be any trust there? And I know that, go please, Sam.
Sorry, I know we're running out of time, but I just really quickly wanted to say that somebody in the chat had mentioned that I actually met her at the previous panel that I just spoke about. And we were talking about the importance of follow-up or next steps and actions after different panels and meetings and sessions like the one we're having today, towards a point of being able to say okay, we did this thing and we actually are gonna hopefully see some changes in these areas because of it, as opposed to we all got together for a brief moment in time and that was really good and affirming, but now it's over. So that just makes me wonder if there are any plans for follow-up or next steps coming out of today's session.
That is what I was hoping we could close on, is thinking about what would be the best way to proceed from here. I heard maybe going out into the community meeting in a different place. And what do you have any ideas about how we can take action and try to address some of these systemic issues?
Community clinics. That is community clinics that address our specific needs, but then also our general human needs. So COVID testing, but also HRT, or, you know, resources about free access to HRT or surgery, community clinics, like address our health, our mental health, our physical health, our transitions, our identity, our sense of self, our sense of security. Yeah, and make it accessible. I think that is an action item. Like, I would love to see you all email me and tell me about the Duke sponsored sessions that, you know, community clinics that are going to be taking place at El Centro Hispano, it's right down the street from you. And, you know, partnering with EqualityNC, and they will help you find a physical location. I'm speaking these things into existence and calling it out because this is being recorded. So that's what I'm looking for. Otherwise, Duke can keep the money. You know, I love you all personally, but I'm just keeping it real. I'm like, yeah, this talking, I love all these people up here. I can talk to them offline when I don't have to worry about, you know, wearing, you know, this cute blazer that I picked up. But yeah, action items, like seriously, do something and do it now. You know, if they're not giving you the money, okay, you have a medical license. You have a brain. Offer yourself. That's just mine.
I love
I'm
Candace.
sorry.
I love Candace. You're so eloquent with like the way that you like just can describe something in such a poignant, powerful way. It's a gift. I wish I was that. That gift. For the rest of the panelists, do you have any other ideas? We're at 12 o'clock, and I don't want to. You know, we have one more speaker. So, any other closing thoughts, ideas?
I would just like to hear about some of the different ways that you and Dr. Lewis both feel like you are troubling the system that we're currently within. Like, I don't know, even if it's like a newsletter or something that comes out like once a month or something, but like something that shows like in an ongoing way that work is actively being done to change some of the structures that we are currently having to struggle to try to exist within.
I think I can commit to that for sure. I think it would also be great to have like a community advisory. We have a community advisory board, but maybe one that is that we can do. Yeah, that's more specific to this. I think there's some very unique needs with this particular like intersecting group. So we can hyper focus on this.
These perspectives are really so important. It reminds us of like the importance of getting outside of the Duke community and actually engaging with people and meeting folks where they're at. I know I would love to be a part of an initiative that actually goes to a place like Centro Hispano, or a program that actually leaves this like protected little space of Duke and is actually working in an active way, like Rebby said, as like co-conspirators for justice in these different aspects, because I realize that as much as we do in these little clinical environments, it's important, not the work that we're all trying to do matters outside of this like small square mile of space. So I know that I will definitely be open to and looking for opportunities to try to extend this work and beyond just our Duke little bubble, but actually getting involved in other institutions. I've been to the LGBT Center of Durham when I first moved here and went to some programming there. And there's a lot of important initiatives. Even though we're in the Zoom era, it's so hard to travel. I think little things like bringing COVID testing out into the community is so important. We have a COVID testing center that's a drive-up facility here at Duke, but it's here at Duke. I think we need to have those resources in a more disparate fashion so that people can get to them. Little changes like that and meeting folks where they're at is going to be an important part of our systemic response.
I would like to see a potential consortium or cooperative effort between the research institute that helped sponsor this event, the many organizations that are here represented present today, and a formal community needs assessment on the intersectionality that we were discussing today. When we talk about EDIC and EMIC perspectives, EMIC being from within the community, EDIC being outside looking in terms of sociology and anthropology, it's important to really drive in on the EMIC perspectives. And so if we can somehow draft, formulate, propose a formal research proposal collaboratively between some of the organizations here and the research institutes that help sponsor this discussion at Duke for a formal community needs assessment, I feel like we can begin to really address some of the intersecting issues.
Thank you, Vanity. I love that idea, and I'm sure we will be talking with the directors of the institutes afterwards about next steps. I just want to thank you all for your genuine openness, honesty, and presence, and glamour, and overall fabulousness. I just love it. It's giving me life. And I feel honored that you all were willing to, I think Don Taylor said that this did not come without a cost to each of you and sharing these vulnerable things. And I want to acknowledge that as well and say thank you. And I hope that, I'm committed. I'm going to say I'm committed to making the next steps to solve some of the issues that have been brought to light here.
Thank you, everyone.
Thank you.
Thank you.
Thanks, everyone.
Thank you.
We'll be in touch.
Thank you, everyone.
Thank you, everyone.
And I believe we have our closing comments by Dr. Rosa Gonzalez Guarda.
Yes. Good afternoon, everyone. And I believe that my video has been disabled. So hopefully we can figure that piece out soon so I can join you here in this. Oh, there we go. Hello, everyone. So before I share some of my thoughts, I just wanted to, again, mimic what and emphasize what Dr. Whicker said in terms of expressing my gratitude for sharing what is, particularly vulnerable experiences with us. And I think it's ironic that the name of this session is really focusing on mistrust and misinformation, and that you all the panelists, and particularly this last one, really did place a great deal of trust in us in sharing their experiences. And it's something for us to take serious, because with that trust is a great deal of responsibility in what we do with information and vulnerabilities that were shared with us, in translating that into change and to action. To continue with some of my ideas, I just want to say that it is an incredible honor for me to be here with you all this morning and what has turned into an afternoon. And it's also an incredibly daunting task to try to think through some of the major themes that I've heard and really give praise to the incredible information and lived experiences that have been shared with all of us. So my name is Rosa Gonzalez Guarda, and I am an associate professor at Duke University School of Nursing. And one of the roles that I have there is that I lead our population health research efforts for the school. And I also have a role in our CTSI, our Clinical Science Translational Institute, where I'm one of a few co-directors of our Community Engaged Research Initiative, where we really try hard and we continually need to do a better job at this, of really facilitating community academic partnerships around research that is meaningful and responsive to the needs and priorities of the very diverse communities that we are here to serve. I'm also the principal investigator of the Ser Hispano study, which is a study of stress and resilience in the Latinx immigrant community. And I have the wonderful fortune of being able to partner with the Centro Hispano, and Pilar Rocha Goldberg, who you all heard from earlier today, is one of the co-investigators on our study. And we have staff from El Centro that are really key in our research efforts. So that's sort of the frame that I have in terms of my experiences and the different hats that I wear that will shape some of my comments. And what I would like to do is just go through this morning and highlight some of the themes that I noted across the sessions. And then I wanted to share some of the exciting things that we're doing in the CTSI and at Duke more broadly to address some of these issues. And then finally close off with some things that I think that we can do in terms of actions that result from this. So just starting from the beginning today, I want to just highlight the issue and really the stark reminder of the COVID-19 pandemic and how it's disproportionately impacted communities of color and underrepresented groups in research. And from the talks that we've learned earlier on in the morning is the realization that COVID-19 is really rooted in structural and systemic racism. And in terms of thinking how to solve that, we're going to need to have new tools in our toolbox, where while we're investing all this money in vaccine development, we're going to equally or more so need to invest money in really addressing the social root causes of this pandemic. And I think that, one of the orientations I take in my research is a syndemic orientation, which considers co-occurring epidemics or co-occurring pandemics and tries to understand why do these cluster in certain populations. And they cluster for many reasons that we talked about this morning, really being rooted in racism, xenophobia, and white supremacy. So in our race to develop a vaccine, we have to invest even more resources in our race to address these fundamental causes of these conditions. And in the second, well, in the first session after this keynote, we really started hearing about some of the potential ways that we can go about doing that. And really fundamental to us addressing the reasons for trust or mistrust or distrust in the community is really thinking about relationships and relationship building as an antidote to some of the problems that we're seeing. And really in that session, the idea that was highlighted most, or one of the ideas that was highlighted most for me, was the idea around the importance of listening and being humble. And that's something we certainly carried out through in this last session that we heard. And then the other thing about that listening and being humble is really listening, not just for the listening's sake, but having action that results from that. And if listening isn't preceded with action, then I think we have the potential to exacerbate a lot of the mistrust that is already existing in our community. In the session 2, we learned a lot from the lived experiences of the participants of that panel. And one of the things that was striking to me is in thinking of intersectionality, the intersecting streets of race, class, gender identity, sexual orientation. We heard about the experience of, we opened talking about what are some bad experiences that you've had, and the realization that almost every experience is an undesirable experience or an unpleasant experience when you come from it from these intersecting identities, and when the systems that are there to serve are not really inclusive of those intersecting identities. So in terms of thinking through of some of the things that we're doing at Duke and in the community that I think are promising, I like to just raise this new relationship that has really been in development and enhanced between the Social Science Research Institute and the Duke CTSI. It really speaks to the recognition of our health system and infrastructure that in order to make advancements in population health, we're going to need to address the social drivers. I'm also excited and want to share that our new Clinical Translational Science Institute, our new application is really focused on issues of disparities, inclusion, and racial equity. And we have, one of the main themes is around accountability, transparency, and trustworthiness of research to enhance equity and trust. We have a new core within that group that, and you saw a lot of representatives here in the discussion today, which is the Equity and Research Core with Dane Whicker, Keisha Bentley-Edwards, who's participating also, and Nadine Barrett as co-leaders of that. As part of that, there's a trust survey that we're going to be launching to be able to identify some of the issues around trust and mistrust, as well as generate ideas of what we need to do in order to advance that. And I just posted in the chat an activity that we're going to be having, a virtual dialogue to get ideas of how to best design that work so that we really get the kind of information that we can act on. And then the other thing that I think that is happening organically in our community, which speaks to our need to really go outside of the walls of Duke and really invest in the wonderful, awesome work that is happening in our communities, is that we're seeing a number of coalitions coming together to address issues of importance for underrepresented groups and groups that are most affected by COVID-19. I happen to be part of the Latin 19 group, which is a multi-stakeholder group that has come together to address issues unique to the Latinx community. And one of the things that have been really rewarding as part of the work in that group is the ability to connect decision makers, which was a theme I heard today, decision makers that might have that power and privilege with the people who have the know-how, the people who have the lived experience. And that connection has really, and listening has really resulted in actions that have been resolved after a 1-hour phone call. And there's similar groups in the Black community, in the homeless community, and with older adults that are opportunities for all of us to, particularly those of us that are at Duke that need to get outside of Duke to integrate into those things. So I know that we've reached our last, I'm one minute over here, so I'll just try to summarize this and be brief in terms of what I think we can do, what else we can do to address this work. First, we need to listen. We need to be humble and continue to listen. We need to ask about what the needs are and the solutions. And Vanity had a great idea about us investing in doing a needs assessment that has this intersectional perspective to be able to capture those identities and the impact that intersecting identities have on health. We need to be engaging folks well before we need anything. Now in the age of COVID-19, where Duke is really trying to get representative samples in COVID-19 research, we've come to the realization that it's really hard because we haven't always done due diligence in investing in the relationships that we need to really develop the trust that will be required for people to be part of the solutions, the research driving these solutions. And then finally, and most importantly, we really need to act. These conversations are really wonderful beginning that need to be followed up with some actions. And today we talked about a number of actions related to the quality and access to healthcare, having comprehensive plans for addressing issues of inclusion and diversity, and equity, which include policy, training that's just not just one-shot training, but really comprehensive and repetitive. And then also having some evaluation around that to make sure that it has impact. And then as many have shared, we really need to go outside of the walls of Duke. We have to go into the community organizations that are doing this great work. We've heard from many of them this morning. I just shared with you the COVID specific work groups that are opportunities for us to be integrated. And then in doing that, we really need to make sure that we are linking the power and the privilege to the voices of the lived experience to make that impact. So thank you so much for this morning. I want to thank you all, particularly all the panelists and the participants that made time to listen to these issues and to brainstorm together about possible solutions. I'm really, as despairing some of the statistics are and the experiences that we've heard this morning, I am also equally optimistic about the potential power that we all have when we pull together to address this as one community. Thank you so much.